Hello everyone. In this video, we will discuss in details about the adrenergic or sympathetic nervous system, its key receptors, clinical applications of adrenergic drugs, and treatments. At the very beginning, a quick recap. The sympathetic system originates from the thoracic and lumbar region and forms a connection in the ganglion, which is near the spinal cord. The preganglionic fibers are small and the postganglionic fibers are long. The neurotransmitter, like in every preganglion, is acetylcholine, whereas the postganglionic fibers mainly secretes noradrenaline. Just like the parasympathetic system we discussed about acetylcholine, here we will discuss in details about noradrenaline. So, how noradrenaline is synthesized? Noradrenaline is actually produced and stored in the nerve terminals. Now, from where does this noradrenaline come? The answer is the same, as noradrenaline is produced by this neuron. This is a neurotransmitter. But for noradrenaline formation, the raw material is taken from outside, which is tyrosine. So, the first step is that tyrosine comes from outside. Then tyrosine is converted to dopa by an enzyme called tyrosine hydroxylase. This is the rate limiting enzyme in the formation of noradrenaline. Dopa is converted into dopamine, and dopamine will enter in the vesicle and form noradrenaline. This noradrenaline is stored here. So whenever a nerve impulse comes, the noradrenaline is released in the synapse. Now this noradrenaline works on receptors and sympathetic action occurs. From our previous video, we know sympathetic action is to stimulate the heart but relax most other parts of the body. Now we want to stop the action, and the major method of termination of action is noradrenaline reuptake. It goes back in the vesicles and the action stops. Just like in parasympathetic system, the main action of sympathetic system is due to presence of noradrenaline in the synapse. So, if we increase or decrease the level of noradrenaline here, we can stimulate sympathetic activity. What are the options we have? We can actually inhibit the rate limiting enzyme tyrosine hydroxylase. We can inhibit the entry of dopamine into the vesicles. We can inhibit the release of noradrenaline in the synapse. Three drugs can be used to decrease noradrenaline in the synapse. The drug that inhibits the tyrosine hydroxylase enzyme is called metyrosine. Metyrosine, again from the name, we can remember metyrosine, the name says I am tyrosine. So the enzyme tyrosine hydroxylase gets confused about where to act because the drug metyrosine is saying that I am tyrosine, I am tyrosine. In this confusion, the enzyme will stop working. So metyrosine is a competitive inhibitor of tyrosine hydroxylase. Now, the drug that blocks the entry of dopamine into the vesicle is called reserpine. The third drug that inhibits the release of noradrenaline in the synapse is guanethidine. So, these three drugs methyrosine, reserpine, and guanethidine. They decrease noradrenaline in the synapse, thereby decreasing the sympathetic activity. Similarly, if we give a drug that inhibits the reuptake of noradrenaline, the noradrenaline does not go back, it will stay here. This will produce more sympathetic action, and the drug that inhibits the uptake of noradrenaline is cocaine. So, cocaine is a reuptake inhibitor. It will increase noradrenaline in the synapse, which will increase sympathetic activity. Now, the next thing we need to discuss is about the receptors. The receptors of sympathetic system are mainly of two types: alpha receptor and beta receptor. Alpha receptor are further divided into alpha 1 receptor and alpha 2 receptor, and beta receptor are of three types: beta 1, beta 2, and beta 3. We will start the discussion from alpha 1. Although alpha 1 receptor are present all over the body, you need to remember three main areas which will solve all your concepts. These three places are: it is present on the blood vessel, where the main function is to cause vasoconstriction. Second, alpha 1 is present in the eye, where the effect is to cause mydriasis or pupillary dilation. Thirdly, alpha 1 is present on prostatic urethra. We all know the effect of sympathetic system on urine outflow from our previous video, that it decreases the urine outflow. So the alpha 1 receptor in the prostatic urethra decreases the urine outflow. In which prostatic condition urine outflow is already less? Yes, it is benign prostatic hyperplasia, BPH. So what will you like to do with alpha 1 in the treatment of benign prostatic hyperplasia? Obviously, you will like to block the alpha 1 receptors. So alpha 1 blockers like tamsulosin, prazosin are used for benign prostatic hyperplasia. We will discuss in details about it later. So alpha 1 receptor is present mainly at three locations: blood vessel, eye, and prostatic urethra. Now coming to alpha 2 receptor. Receptors may be present here, means postsynaptically, like we discussed earlier, M1, M2, M3, and just now alpha 1. But some receptors are present here also. And alpha 2 is such a receptor. So alpha 2 is a presynaptic receptor. Now compare this whole system with a vehicle or car. When we want to drive a car, we require two most important things. One is accelerator and the second one is braking. The noradrenaline is synthesized and released here and stimulates this receptor. So this acts as sympathetic accelerator. But we also require brakes in the car to avoid accident. So this alpha 2 receptor acts like a brake. That means whenever we stimulate this alpha 2 receptor, it will inhibit the release of noradrenaline by feedback inhibition. When noradrenaline does not come, sympathetic activity stops. So simply you need to remember that alpha 2 is acting here like a brake. So alpha 2 acts like a brake to the sympathetic system. Now, there are some alpha 2 receptors located postsynaptically. These postsynaptic alpha 2 receptors are indistinguishable from alpha 1 receptors, meaning postsynaptic alpha 2 also works like alpha 1 receptor. That means if a postsynaptic alpha 2 receptor is present in the blood vessel, they will cause vasoconstriction. If a postsynaptic alpha 2 is present in the eye, it will lead to mydriasis or dilation of the pupil. So you can simply remember that postsynaptic alpha 2 is equal to alpha 1, but they are very few in number, so you do not need to remember them. But mainly you need to remember their action as a presynaptic receptor. They act like a brake. Alpha 1 receptors are present in blood vessel, eye and prostatic urethra. Now coming to beta receptors. We have three receptors: beta 1, beta 2 and beta 3. Out of these, the beta 3 receptor mainly present in adipose tissue or fat cells, and some are present in urinary bladder. The stimulation of this receptor mainly causes lipolysis, means breakdown of lipid. We will not study beta 3 receptor anymore, just remember it causes lipolysis. So effectively we have two beta receptors only, beta 1 and beta 2. It is very easy to remember. You can remember that we have one heart and two lungs. So beta 1 receptor is present in the heart and beta 2 receptor is present in the lungs. Beta 1 will stimulate the heart, whereas beta 2 inhibits the bronchus. So it will lead to bronchodilation. Now, apart from the heart, beta 1 is present at one more location, which is juxtaglomerular cell of kidney. So the beta 1 receptor is present in the heart and juxtaglomerular cells of kidney. In heart, it stimulates the heart, whereas in juxtaglomerular cell, the beta 1 receptor stimulation leads to increased secretion of renin. You remember in parasympathetic system, we discussed M1, M2 and M3 receptor. The last M3 receptor was present everywhere. Similarly, here in sympathetic system, we discussed at last about beta 2 receptor. So, beta 2 receptor is present everywhere. Beta 2 is present mainly in the lungs, means the bronchus. It is present in the gastrointestinal tract. It is present in the urinary bladder. It is present in the glands. It is present in the uterus. It is present in the blood vessel. It is present in the skeletal muscle. It is present in the liver. As we discussed, the sympathetic system stimulates the heart and relaxes most other part of the body. We know in heart we have beta 1, so it is stimulatory. In all other parts we have beta 2, so it is a relaxant. Most other places beta 2 will cause relaxation or inhibition. So it will relax the bronchus, it will relax the gastrointestinal tract, it will relax the urinary bladder, it will relax the glands, it will relax the uterus. Relaxation of the uterus is called tocolytic effect. When do we want to relax the uterus? It is used in preterm labor. We want to relax the uterus. As there is beta 2 receptor, we want to stimulate it so that uterus can dilate and no preterm labor will occur. It will also relax the blood vessel. But the important thing we discussed earlier that alpha 1 is causing vasoconstriction, and just now we discussed that beta 2 will cause vasodilation. So first of all, how to remember which receptor causes vasoconstriction and which receptor causes vasodilation? To remember that, we will go back to our primary class where we were taught about ABCD. A, B, C, D. In primary class, we were also taught counting 1 and 2. Now we just need to put the arrow. You can remember A1 means alpha 1 and it will cause C, and C here means constriction. B2 means beta 2 and here D means dilation. So alpha 1 will cause vasoconstriction and beta 2 will cause vasodilation. Now the question is, both receptors are part of sympathetic system. So when the sympathetic system is stimulated, what will happen to blood vessels? Because these two have opposite effects. The effect on blood vessel will depend upon which blood vessel has which receptor in more quantity. If a blood vessel contains more alpha 1 receptor, that will contract. If a blood vessel contains more beta 2, that will dilate. Now the question is, which blood vessel contain more alpha 1 and which blood vessel contain more beta 2? This is also easy to remember. Suppose a lion comes in front of us. What can we do at this time? Either we can fight with the lion and kill it. Obviously, we are not superhero to kill the lion. Or the second option, which is better option for us, to run away. So when we see a lion, we will try to run away, and we can run away if we have power in the muscles. We will also require power in the heart. Whenever we want to run away in emergency, we require sympathetic activation. So the sympathetic system will be activated and it will help us to run away. This means when the sympathetic system is activated, it should increase blood flow to the muscle and increase blood flow to the heart. So blood vessels of heart, which is coronary artery, and blood vessels of skeletal muscles will dilate when there is sympathetic overactivity. And dilation caused by which receptor? Yes, it is beta 2. So skeletal muscle and coronary arteries contains more beta 2. The question is, normally we have 5 liters of blood in the body. When a lion comes in front of us, it will not become obviously 10 liters. So when the blood remains 5 liters, where does it come from? What happens is that in all other blood vessels, alpha 1 is more. So blood vessels of skin, internal organ contains more alpha 1 receptors. So whenever there is an emergency, there will be vasoconstriction in this area because alpha 1 is more here. This blood is shifted to heart and muscles so that the person can run quickly. So alpha 1 receptors are more in the skin and internal organ, whereas beta 2 receptor are more in the blood vessel of heart, means coronary arteries and skeletal muscles. So this is the effect of the sympathetic system on blood vessels. Now our next organ is skeletal muscle. Apart from blood vessels, beta 2 receptors are also present on the skeletal muscle spindle, and stimulation of beta 2 receptors in the muscle spindle result in tremors. This is why whenever there is sympathetic overactivity, there is presence of tremors. We develop tremors when the lion comes in front of us. We develop tremors before the exam because sympathetic system is overactive. We also develop tremors while proposing to someone because the sympathetic system is active. So sympathetic system leads to tremors. Now the last organ is liver. There is presence of beta 2 receptor in the liver. Before discussing the action of beta 2 in liver, we need to answer some important question. Which is more dangerous? Think, hypoglycemia or hyperglycemia? Obviously, hypoglycemia is more dangerous. Hyperglycemia means diabetes. You must have seen many diabetic patients who have uncontrolled blood sugar and do not develop problems for many years. But hypoglycemia, if it is persistent for just 1 minute, the person will go into a coma. So hypoglycemia is an emergency, and our sympathetic system helps us to protect against emergencies. So the sympathetic system will try to protect us from hypoglycemia. How will it protect? Whenever a person develops hypoglycemia, the sympathetic system becomes overactive. When the sympathetic system is overactive, it will stimulate beta 1, beta 2, and in case of sweat gland, the sympathetic cholinergic system. When beta 1 receptor is stimulated, it causes tachycardia. And when severe tachycardia occurs, it can lead to palpitation. Stimulation of beta 2 receptor will lead to tremors, and stimulation of sympathetic cholinergic fibers in the sweat glands leads to sweating. So when a person develops sympathetic overactivity, as in the case of hypoglycemia, the person will develop tachycardia, palpitation, tremors, and sweating. These are called warning symptoms of hypoglycemia. Remember, hypoglycemia more commonly occurs in patients with diabetes. If they skip meals or take anti-diabetic drug in larger dose, may develop hypoglycemia. Whenever they develop hypoglycemia, these symptoms will come. Whenever these symptoms come, the person should take sugar, cookies, or juice. So hypoglycemia will be reversed and the person will not go into a coma. This is very important. Warning symptoms of hypoglycemia. This should be told to every diabetic patient. Now, suppose a person comes to a doctor, but the doctor is not aware of these symptoms. If the doctors do not tell him about these symptoms, when these symptoms are not told, the person will not take sugar. What will happen? Will the person go into a coma? No, the person will not go into a coma because now beta 2 receptor, which is present in the liver, will be stimulated. We know the liver is the site of metabolism. When beta 2 is stimulated in the liver, it will shift the metabolism in such a way that blood sugar start increasing. So there will be stimulation of gluconeogenesis. There will be stimulation of glycogenolysis. There will be inhibition of Glycogenesis. Gluconeogenesis causes increase in glucose or blood sugar. Samely, glycogenolysis also increase blood sugar, and inhibition of glycogenesis also increase blood sugar. That's why sympathetic system is very important to protect against hypoglycemia. It protects by two main mechanisms. One is by showing the warning symptom palpitation, tremor and sweating, and other by reversing hypoglycemia. This is the reason if we give beta blockers to a diabetic patient, they are very dangerous drugs. If we give beta blockers in this patient, what will happen? This will result in masking of all the symptoms. That means even if the person has hypoglycemia, the symptoms will not come. The person will never know that he is having hypoglycemia, and the person will not take any sugar. Now, the second thing is, if a person does not take sugar, the liver will reverse the hypoglycemia, but we have blocked it by beta blocker. That means even reversal cannot happen. So there is a high chance that a person can go into a coma. So beta blockers are contraindicated in patient of diabetes. Now one very important question that you need to know: which symptoms of hypoglycemia will be present even if a person is taking beta blockers? The answer is sweating. Remember, sweating is mediated by acetylcholine, meaning M3 receptor, and we have blocked beta receptor by beta blocker. Here you can see the sweat gland is a part of sympathetic nervous system, but acetylcholine is its postganglionic neurotransmitter. So here is M3 receptor on sweat gland. Acetylcholine acts on this M3 receptor. So there is no beta receptor at sweat gland, and as a result, sweating is the only reliable symptoms of hypoglycemia in diabetic patients taking beta blockers. So we have discussed about the sympathetic nervous system's receptors. Now we will get a quick recap. The alpha 1 receptor is located at blood vessel, eye and prostatic urethra. The alpha 2 receptor mainly act as a brake. The beta 1 receptor is located at heart and juxtaglomerular cells of kidney, and in rest other location the beta 2 receptor is located. With this basic understanding, we can now discuss the drugs acting on these receptors. Just like the parasympathetic system, the drugs acting on sympathetic system can also be divided into sympathomimetics and sympatholytic drugs. Sympathomimetics are those that stimulate the sympathetic system, while sympatholytics are those that block the sympathetic system. We will start the discussion from sympathomimetic drugs. Now, sympathomimetic drugs are further classified into directly acting and indirectly acting drugs. Directly acting drugs will directly stimulate the receptor, but indirectly acting drugs are mainly of two types. One we previously discussed, the reuptake inhibitor, and another group of drug is displacer. Drug that inhibit the reuptake of noradrenaline, it will increase sympathetic activity. The main drug that acts by inhibiting the reuptake is cocaine. Another drug which act by inhibiting this is tricyclic antidepressant. These drugs will be covered later. Cocaine will be discussed in anesthesia, and TCA will be discussed in central nervous system. The second group of drug that act by displacing the noradrenaline, the example is tyramine. First of all, how does this tyramine work? We know that noradrenaline is stored in the vesicle, and every vesicle has a fixed capacity. Suppose this vesicle has the ability to store 50 molecules of noradrenaline. So the vesicle has maximum capacity of storing 50 molecules of noradrenaline. Normally, all of them are neurotransmitter. If we give a drug like tyramine, which has the ability to enter into the vesicle, suppose we give 25 molecules of tyramine in our first dose. So what will happen? These 25 molecules of tyramine will enter into the vesicle. Now, the total molecule inside the vesicle is 75, but it cannot store 75. So it will displace 25 noradrenaline. So here it will become 25 noradrenaline in the vesicle. And the displaced 25 noradrenaline will work on this receptor and stimulate the sympathetic nervous system. If we give a second dose of tyramine with 25 molecules again, it will again enter into the vesicle. Now this time, this will displace the remaining 25 noradrenaline. So the 25 noradrenaline will again produce the action. But when we give a third dose of 25 molecule of tyramine, it will enter into the vesicle. Now it will become a total of 75 molecule of tyramine in the vesicle. Now there is no adrenaline that can be displaced. So the excess 25 tyramine is now displaced. When tyramine comes into the synapse, it cannot produce the action because it cannot act on the receptor, and the sympathetic action will suddenly stop. This phenomenon is known as tachyphylaxis. Tachyphylaxis is divided into two parts. Tachy means rapid or fast, and phylaxis means development of tolerance. When we give a drug like tyramine, it will produce action for 2 or 3 doses. But after that, suddenly the tolerance will occur to their action. Remember, normally tolerance is slow to develop, but in these drugs, the tolerance is very rapid to develop. So, tyramine like drugs act by displacement can show the phenomenon of tachyphylaxis. So, displacers show the action of tachyphylaxis. So, the main displacer is tyramine. There are some other displacer drug also. Those are ephedrine, pseudoephedrine, and amphetamine. Tyramine acts by displacement only, but the other three drugs, ephedrine, pseudoephedrine, and amphetamine, after displacing the drug, it acts on the sympathetic receptors. They have mixed action. So, ephedrine, pseudoephedrine, and amphetamine have the displacement action like tyramine, and they can also directly stimulate the sympathetic nervous system, as they have both direct and as well as indirect effects. Now, important points regarding these individual drugs. Tyramine is present in large quantity in cheese. Cheese contains plenty of tyramine. The clinical importance we will discuss in antiadrenergic drugs. The next two drugs, ephedrine and pseudoephedrine, are act as nasal decongestant. So they are used in colds when nasal congestion is present. How these work as nasal decongestant? As they stimulate the alpha 1 receptor, they causes vasoconstriction. So blood supply to the nasal mucosa is reduced, and as a result there is less edema and less fluid secretion. So ephedrine and pseudoephedrine act as nasal decongestant. Lastly, amphetamines are the drug that can cross the blood-brain barrier. So they enter into the brain and produce two main important effects. One, they reduce sleep, and the second, they increase attention span. So that means they are called CNS stimulants. The use of amphetamine, although they are highly addictive drug, is based on these two functions only. The first function is to reduce sleep, and this action is utilized in a condition called narcolepsy. Narcolepsy is a disease characterized by sleep attacks. In narcolepsy, what happens? The patient develops sleep attacks. Sleep attacks literally means sleep attacks. The person can suddenly sleep. You can assume a person is driving a bike and suddenly sleeps. A person is swimming and suddenly sleep. It can lead to fatal accidents. So we do not want these sleep attacks. So we give a CNS stimulant drug like amphetamines. They decrease sleep, which will lead to a decrease in number of sleep attacks. Now, the second action of increasing attention span is utilized in a condition called attention deficit hyperactivity disorder, ADHD. This disorder is commonly seen in children. Attention deficit does not mean that parents are not giving attention. Attention deficit means the child has less attention span. Less attention span means the child is not able to concentrate on anything. When the child is not able to concentrate, the child gets bored easily. So, what happens is that the child starts playing with some game, not able to pay attention. So, he quickly gets bored and takes another game. Again, after playing this game for some time, he gets bored and start playing another game. And after some time, the child thinks that they have nothing to play with. So the child become irritable, leading to hyperactivity. Hyperactivity is an indirect result of inattention. The primary problem is inattention, which lead to irritation and subsequently hyperactivity. So in ADHD, the primary problem is decrease or lack of attention span. When we give amphetamine, they increase the attention span, which will treat ADHD. And the drug of choice for ADHD is methyl amphetamine. So now we will move to our directly acting drugs. Directly acting drugs can be divided into two groups, catecholamines and non-catecholamines. The first question is, what is a catecholamine? Catecholamine is actually a chemical name that consists of catechol and amine. If you remember chemistry, the chemical structure of dihydroxybenzene is called catechol. If an amine group is added to the catechol group, it will be called catecholamine. This means any drug having this type of chemical structure is called a catecholamine. If this is absent, it is called a non-catecholamine. The important thing to know is that this chemical structure of catecholamine can be recognized by some enzymes in the body. And the name of the enzyme is catechol O methyl transferase, COMT. This enzyme COMT can recognize any drug that contains this chemical structure. And this enzyme is present in large quantities in the gastrointestinal tract. So if any person takes any catecholamine orally, COMT is already waiting here to break it down. Therefore, no catecholamine will be effective orally. So that is the important thing to know from here. Catecholamine cannot be given orally, whereas non-catecholamine can be given orally. Catecholamines are further divided into endogenous catecholamine and exogenous catecholamine. Endogenous catecholamines are normally present in the body, whereas the exogenous catecholamines are given from outside. The endogenous catecholamine includes adrenaline, noradrenaline, and dopamine. And the exogenous catecholamine includes dobutamine, isoprenaline, and phenoldopam. So, first we will cover the catecholamine, then we will cover non-catecholamine. Among these drugs, we will start first dopamine. Now, for knowing about any drug, the most important thing is to know on which receptor it works. Dopamine works on three main receptors: D1 receptor or dopamine receptor, beta 1 receptor, and alpha 1 receptor. The important thing is the sequence. At a very low dose, dopamine causes stimulation of only D1 receptor. And if we increase the dose, it is stimulating both D1 and beta 1 receptor. And at high doses, it can stimulate all the three receptors. So if you remember the dose of beta 1, you can automatically remember the other two. The dose of dopamine for stimulation of beta 1 receptor is 2 to 10 microgram per kg body weight per minute. That means if we give less than 2 microgram per kg body weight per minute, it will only stimulate D1 receptor. And if we give more than 10 microgram per kg body weight per minute, it will lead to stimulation of D1, beta 1 and alpha 1 together. Now we already discussed about beta 1 and alpha 1. Beta 1 is mainly present in the heart and alpha 1 is mainly present in the blood vessel, which causes vasoconstriction. We did not discuss about D1 receptors or dopamine receptors. Dopamine receptors are also present in the blood vessels. Their main function is to cause vasodilation. Dopamine D1 receptors are present in all the blood vessels of the body and they causes vasodilation. But they are in highest concentration in the renal vessel. So when we give dopamine, it can stimulate D1, beta 1 and alpha 1. Based on that, we can find the use of dopamine. Dopamine stimulates beta 1 receptor, meaning it will stimulate the heart. In which condition do we want to stimulate the heart? Yes, we want to stimulate the heart in congestive cardiac failure. So dopamine is used in congestive cardiac failure. And the dose of dopamine will be 2 to 10 microgram per kg body weight per minute. Now, dopamine can also stimulate the alpha 1 receptor and which causes vasoconstriction. In which disease do we need vasoconstriction? Yes, we need vasoconstriction in patients with shock. So, dopamine we can given in high dose more than 10 microgram per kg body weight per minute in the patients with shock. So, dopamine, when given in high doses, will cause vasoconstriction, which will increase blood pressure, so it can treat shock. But the additional advantage of dopamine is that at high doses, it stimulates all the three receptors. This means it will stimulate D1 receptor also. By stimulating the D1 receptor, it will cause vasodilation in the kidney. Whenever it causes vasodilation in the kidney, the glomerular filtration rate will be increased. That will lead to improved renal function. So, dopamine alone is the drug of choice for patients in shock with oliguria. It will not only treat the shock by vasoconstriction but also reverse the renal failure by vasodilation. That is the important thing to remember about dopamine. One more thing, you can find out that the drug name that contains dopa will stimulate D1 receptor. If dopa is not present in the name, the catecholamine or non-catecholamine will not stimulate D1 receptor. Now, why are we talking like that? The second drug we are going to discuss has a very similar name to dopa, and the name is dobutamine. But if you see carefully, dobutamine does not contain dopa. So, dobutamine does not act on D1 receptor. That is the most important thing to remember, that dobutamine does not act on D1 receptor. Rather, dobutamine primarily works on beta 1 receptor. So, it will stimulate the heart and it will mainly used for congestive cardiac failure. The major use of dobutamine is congestive cardiac failure. Now, if you see another drug named phenoldopam, see it carefully. Its name also contains dopa. So, that means it will also stimulate D1 receptors. If you read the name again, phenoldopam will look like only dopa. That only dopa means it will stimulate only D1 receptor. Phenoldopam, even at high doses, stimulate only D1 receptors. So, when it stimulates only D1 receptor, it will cause vasodilation in the whole body. When it causes vasodilation, it can be utilized in hypertensive emergencies. So now we are left with three drugs in this category. We have discussed about dopamine, dobutamine and phenoldopam. Now the three drugs which are left is adrenaline, noradrenaline and isoprenaline. We will cover all the three drugs, adrenaline, noradrenaline and isoprenaline together. Adrenaline is also called epinephrine and noradrenaline is also called norepinephrine. For knowing about these drugs, again the most important thing to remember on which receptor they work. It is very easy to remember, as you can remember adrenaline. A for adrenaline and A for all. So adrenaline works on all the receptor, means alpha 1, alpha 2, beta 1 and beta 2. We have four main receptors. So adrenaline stimulates all the four receptors. Now second is N for not all. We will start writing alpha 1, alpha 2, beta 1 and suddenly we will remember that not is also written. So we will not write beta 2. So noradrenaline acts only on 3, alpha 1, alpha 2 and beta 1 receptors. Now isoprenaline, which acts on beta 1 and beta 2 receptors only. So adrenaline acts on all four receptors, noradrenaline acts on 3 and isoprenaline acts on only beta receptors. Now we can discuss the effect of these drugs on blood pressure and heart rate. Again, blood pressure is of two types: systolic blood pressure and diastolic blood pressure. Systolic blood pressure, here systo means contraction of the heart. The contractility of the heart depends on which receptor? Yes, it is beta 1 receptor. So if a drug stimulates beta 1, it will stimulate the heart. So it can increase systolic blood pressure. If we see which of the drugs stimulates beta 1 receptor, adrenaline stimulates beta 1 receptor, noradrenaline also stimulates beta 1 receptor, and isoprenaline also stimulates beta 1 receptor. So all three receptors stimulate beta 1 receptor. So all the three drugs will increase the systolic blood pressure. Now the question is, what will be the effect on diastolic blood pressure? Diastole means when the heart is relaxing. And when the heart is relaxing, which factor maintains blood pressure? Yes, it is peripheral vascular resistance, PVR. In simple terms, peripheral vascular resistance means the effect on blood vessels. If there is vasoconstriction, there is more blood pressure, and if there is vasodilation, there will be less blood pressure. So that is diastolic blood pressure. Diastolic blood pressure depends on blood vessels. And which receptors are present on blood vessels? Yes, we have two receptors, alpha 1 receptors and beta 2 receptors. And both of them have opposite effects. Remember, in nursery class, we have learned A, B, C, D, and 1, 2. So, alpha 1 causes vasoconstriction and beta 2 causes vasodilation. So, it will depend upon alpha 1 and beta 2 receptor. If you see adrenaline, you can see that adrenaline stimulates both alpha 1 and beta 2 receptor. Alpha 1 will cause vasoconstriction and beta 2 will cause vasodilation. So, the two will tend to cancel each other and the net effect will be negligible. On the other hand, noradrenaline stimulates only alpha 1 receptor. So, stimulation of alpha 1 will cause vasoconstriction, and only vasoconstriction means it will increase the blood pressure. And lastly, the isoprenaline does not act on alpha 1 receptor. It only stimulates the beta 2 receptor. And beta 2 receptor stimulation causes vasodilation. And this vasodilation will lead to a decrease in diastolic blood pressure. So we noted that all three drugs have different effects on diastolic blood pressure. Adrenaline has a negligible effect. Noradrenaline increases diastolic blood pressure and isoprenaline decreases diastolic blood pressure. So now we can discuss the effect of these drugs on heart rate. One thing to remember that whenever we discuss the effect of any drug on heart rate, we always discuss under two headings. First, what is the direct effect on heart, and second, what is the indirect effect on heart. The direct effect on heart means the drug will directly go to the heart and stimulate its receptor or inhibits its receptor. Which receptor is present on heart? It is the beta 1 receptor. So any drug that stimulates the beta 1 receptor will stimulate the heart and increase the heart rate. We discussed already that all three drugs stimulate the beta 1 receptor. So all of the three drugs will cause a direct increase in heart rate. Now, what is the indirect effect? The indirect effect is the compensatory response of the body. Remember, our body has a compensatory ability for everything. If anything goes wrong in the body, our body will try to rectify that automatically. This is called indirect effect. Now, if the blood pressure increases, the body will try to decrease the blood pressure. If the blood pressure decreases, the body will try to increase the blood pressure. But for that, the body should contain some sensors that can tell the blood pressure is increased or decreased. So the sensor is present in the blood vessels, and the name of the sensor is baroreceptor. And baroreceptor mainly sense the mean blood pressure. So you must be knowing the formula of mean blood pressure from physiology. Mean blood pressure is equal to diastolic blood pressure plus one third of pulse pressure. So the major component here is diastolic blood pressure. One third of pulse pressure is negligible. So we can safely assume that baroreceptor mainly senses the diastolic blood pressure. So what happens when the diastolic blood pressure increases? When the diastolic blood pressure increases, the baroreceptor gets the information and the baroreceptor is stimulated. And whenever baroreceptors are stimulated, they will immediately pass this information to the central nervous system, means brain and spinal cord. Baroreceptor pass this information to the CNS with the instruction that diastolic blood pressure is more. Please reduce this blood pressure. Our CNS has only two arms. One is sympathetic system and one is parasympathetic system. So as the information is that we have to reduce the blood pressure, which arm will be stimulated? Yes, it will be parasympathetic system. So whenever diastolic blood pressure increases, it will stimulate the parasympathetic nervous system. What is the effect of parasympathetic nervous system on heart? Yes, it will decrease the heart rate. This is indirect effect on heart rate. Whenever diastolic blood pressure increases, it stimulates the baroreceptor, which stimulates the parasympathetic part of central nervous system, which results in a decrease in heart rate. The opposite is also true. Whenever diastolic blood pressure decreases, it also stimulates the baroreceptor. And baroreceptor sends the signal to the central nervous system. Central nervous system activates its sympathetic nervous system hand, and stimulation of sympathetic nervous system leads to a increase in heart rate. So if you see carefully, whenever diastolic blood pressure increases, the heart rate decreases, and whenever the diastolic blood pressure decreases, the heart rate increases. So you can safely remember that the indirect effect on heart rate is opposite to the diastolic blood pressure. If diastolic blood pressure reduces, heart rate increases, and if diastolic blood pressure increases, the heart rate decreases. So if we put this information in the table, adrenaline has no effect on diastolic blood pressure. So indirect effect of adrenaline will also be none. Noradrenaline increases the diastolic blood pressure. So it will reduce the heart rate by indirect effect on heart. And isoprenaline decreases the diastolic blood pressure. So indirectly it will increase the heart rate. If we see the final effect on heart rate, it will be simply arithmetic sum of these two heart effect. So adrenaline will increase the heart rate, noradrenaline will decrease the heart rate, and isoprenaline will increase the heart rate. Now, this table is very important for MCQ and CQ questions. Which drug increases systolic as well as diastolic blood pressure but causes bradycardia? The answer is noradrenaline. Here, systolic and diastolic blood pressure is increased, but it causes bradycardia. The second question, which of the following drugs can cause maximum tachycardia? And the answer is, on final effect of heart rate, it is isoprenaline. One more question that seems very simple but highly likely to be marked wrongly. What is the effect of noradrenaline on heart rate in a normal person? Yes, it will cause bradycardia. When it is so simple, why it is likely to be marked wrongly? The reason is that this table is not present in front of our eyes during the examination. At the time, we are simply thinking that noradrenaline is a sympathetic drug, so it should cause tachycardia. What is actually happening? Noradrenaline is a sympathetic drug, but it is causing bradycardia because its indirect effect is very strong. So remember, noradrenaline does not cause tachycardia, it causes bradycardia. Now, the next question, which is slightly difficult. What is the effect of noradrenaline in a patient with transplanted heart? A normal heart and a transplanted heart are very similar. Both contains beta 1 receptors. However, the main difference is that a transplanted heart, we are taking the heart from one person's body and putting it in another person's body. So, when we are putting the heart in another person's body, we will not be able to make small neural connections. This means that in a transplanted heart, there will be no sympathetic or parasympathetic supply. So, in a transplanted heart, indirect effect do not manifest. When only direct action comes, the effect of noradrenaline will cause tachycardia. This is important to remember. In a normal person, noradrenaline causes bradycardia. But in a patient with transplanted heart, noradrenaline causes tachycardia. The reason is so simple. In a transplanted heart, indirect effects do not manifest. Now we can discuss the effect of these drugs. And again, they are very easy to remember. From the receptor, you can remember the uses. So we have adrenaline, noradrenaline, and isoprenaline. Isoprenaline stimulates the beta 1 receptor, which is present on heart. Stimulate the heart. So isoprenaline is used for stimulation of heart in congestive cardiac failure. It stimulates the beta 2 receptor in the bronchus. So it can also be used in bronchial asthma because beta 2 causes bronchodilation, and in asthma we need bronchodilation. So we can use isoprenaline in congestive cardiac failure and bronchial asthma. Noradrenaline stimulates the alpha 1 receptor, which will increase the blood pressure. So we can use it in shock. Alpha 1 in blood vessel will cause vasoconstriction and increase the blood pressure. That's why it is used in shock. It also stimulates the beta 1 receptor, and again for this utility it can be used in congestive cardiac failure. Adrenaline, technically speaking, stimulates all the receptor. So it can be used for almost all these indication: shock, congestive cardiac failure, bronchial asthma. But practically, adrenaline has very few uses. The reason behind it, the adrenaline is very toxic. Slight, a slight overdose can cause arrhythmia and the person can die. The most important use of adrenaline is the drug of choice in patient with anaphylactic shock. The first question is, in this condition, there is shock, meaning the blood pressure is low and we want to increase the blood pressure. But if we look at the table, we can see that for increasing blood pressure, noradrenaline is a better drug. But adrenaline is preferred. In fact, adrenaline is the drug of choice. The reason is that in anaphylactic shock, we also see bronchoconstriction. To treat anaphylactic shock, we need to cause bronchodilation as well. Remember the difference between adrenaline and noradrenaline? A for all and N for not for all. This means noradrenaline does not act on beta 2 receptor and cannot cause bronchodilation. So if we give noradrenaline, it will increase the blood pressure, but the person may die because of respiratory problem. On the other hand, adrenaline stimulates all the receptor, so it can treat shock and cause bronchodilation. That's why adrenaline is the drug of choice for anaphylactic shock. Now, for administration of adrenaline, route of choice is intramuscular. Adrenaline is prepared by intramuscular route. If intramuscular is not given in option, you can mark subcutaneous. But remember, IV should never be answer because intravenous adrenaline is highly arrhythmogenic. It can lead to death of the person. The route of choice for adrenaline is intramuscular. If not in option, then it will be subcutaneous. Now, the concentration of adrenaline used is 1 is to 1000. This means 1 gram of adrenaline is dissolved in 1000 ml of solution. So 0.5 ml of 1 is to 1000 adrenaline is given intramuscular dose. 99% of the patients will improve with this dose. If a person does not improve, then we need to repeat the same intramuscular dose. But the important thing here is this must be done within 10 minutes. It is a serious condition. We cannot wait for a long time. So we need to repeat adrenaline in 10 minutes. Most people will respond to that dose. If still the person does not respond, then in desperate circumstances, we can give IV adrenaline. But for IV adrenaline, the concentration should be 1 is to 10,000. This means we need to dilute the previous one by 10 times. Only then we should give it intravenously. 1 is to 1000 IV adrenaline will cause arrhythmia and the person may die. So if we use intravenous, it is 10 times diluted. And the indication for intravenous is when the intramuscular route has failed repeatedly. Now, adrenaline is also used in cardiac arrest. Now, what do you mean by this cardiac arrest? Cardiac arrest means the heart has stopped working. When the heart is not working, what will be the clinical presentation of the patient? Obviously, the patient will be unconscious because no blood is going to the brain. The person is unconscious and not responding. There will be no pulse and no heart rate. This means the person is almost dead. So, what will we do in this person who has no pulse, no heart rate? Is we will give basic life support, BLS, or in simple language, what we do is CPR, cardiopulmonary resuscitation. So, how do we give a CPR? What is the sequence of events? The sequence of events is CAB, CAB. Here, C means chest compression. At first, we will do chest compression because the heart is not contracting. So, what we need to do is press the heart through the ribs and compress the heart against the vertebra so that the blood can go out. So, just compression. The second thing is airway patency. We need to open the airway. And third thing is breathing. through the open airway. We can give breathing through a bag, ventilator, or mouth-to-mouth breathing, whatever is available. So we will start CPR, cardiopulmonary resuscitation. Have you seen someone giving a CPR? It is a very tiring job. The person who gives a CPR have to compress the chest very strongly 100 times a minute. So within 2 to 3 minutes, the person who is giving the CPR will get very much tired. But with all this effort, if the patient is still not responding, what we can do, we can give adrenaline in IV route. But there is a problem. When the person is unconscious and his heart is not pumping, it is possible that you cannot find the vein of the person. The circulatory system will totally collapse and the vein will not be prominent. So it is impossible to find the vein and inject adrenaline into the vein. So what we can do in this condition, we can use some alternative routes for adrenaline. We can give adrenaline through a very special needle in the long bone tibia. And the venous plexus around the tibia will not be collapsed in such circumstances. So when we give adrenaline in the tibia through this special needle, the venous plexus will absorb the adrenaline from the tibia and will go to systemic circulation. And this route is known as intraosseous route. So when the circulatory system will collapse, we will provide adrenaline through intraosseous route. Think another situation, we do not have this special needle and we cannot give intraosseous adrenaline. So what we can do? We can intubate the patient and can give the drug through this tube. So this route is called endotracheal route. So in life-threatening shock condition, we will provide CPR. If the CPR does not work, we will provide adrenaline through IV route. And if IV route is not possible, we will provide it through intraosseous route. And if we do not have the intraosseous needle, we will provide the adrenaline through endotracheal route. In which condition we can give adrenaline directly into the heart, known as intracardiac route. Only one situation, that is in GTA 5 game. Remember, intracardiac adrenaline is banned a long ago, 2005. Now we will discuss about a very important topic, vasomotor reversal. But for understanding that, we need to know about the biphasic response of adrenaline. Here a quick recall, adrenaline contains A and A means all receptor. So adrenaline works on alpha 1, alpha 2, beta 1, beta 2, all the receptors. And on blood vessel, we know that we have alpha 1 and beta 2 receptor from ABCD mnemonic. So what actually happens when adrenaline acts on alpha 1 and beta 2 receptor? For this, we need to know a few characteristics of these both receptor. Beta 2 has the characteristics of very sensitivity. Beta 2 is a very sensitive receptor. Even at low dose of adrenaline, beta 2 can sense the presence of adrenaline and gets stimulated. On the other hand, for stimulating alpha 1, we need a higher dose. But a characteristic of alpha 1 receptor is it is a very strong receptor. Now, what actually means by very sensitive and very strong, we will understand it mathematically. As beta 2 is very sensitive, suppose we think that beta 2 gets stimulated when there is presence of only 10 molecules of adrenaline. Whereas the alpha 1 receptor needs at least 50 molecules of adrenaline to get stimulated. Now, what will happen after administering 100 molecule of adrenaline intravenously? Now, we will see the graphical presentation. Suppose this is our normal blood pressure and we are administering 100 molecule of adrenaline. So, what will happen is that it will act on alpha 1 receptor, but simultaneously it will also act on beta 2 receptor. But the action will be prominent of alpha 1 because we have said that alpha 1 is very strong receptor. So after providing 100 molecules of adrenaline, the alpha 1 receptor will be stimulated and that will cause vasoconstriction. We know that alpha 1 stimulation leads to vasoconstriction. As a result, the blood pressure will keep increasing. But after some time, the increasing will be stopped because the 100 molecule of adrenaline we have administered, it will start metabolized. So by metabolizing, it will go to 90 molecule, then 80 molecule, then 70 molecule. So as the adrenaline concentration decreases, the blood pressure will start to decrease. And at a point, it will come to 50 molecule. But still, it will stimulate the alpha 1 receptor because alpha 1 stimulation require minimum of 50 molecule of adrenaline. But when the adrenaline molecule will come to 49, what will happen is that the alpha 1 receptor is no more stimulated. So there will be no more vasoconstriction. But now what will happen? This 49 molecule of adrenaline will work on beta 2 receptor because beta 2 receptor stimulation require only 10 molecule of adrenaline as it is very sensitive receptor. So when the adrenaline will act on beta 2 receptor, what will happen? As we know that B stands for D, so beta 2 stimulation will cause dilation of blood vessel. And when the blood vessel is dilated, it will lead to decrease in blood pressure, that means hypotension. Now what will happen is that this 49 molecule of adrenaline will further get metabolized. So it will go back to 40, then the blood pressure will tend to go back to normal a little bit, then it will go to 30, then another little bit, then it will go to 20, then another little bit of increase in blood pressure, then it will get to 20, then another little bit of increase in blood pressure. And when it becomes 9, it cannot stimulate the beta 2 receptor more because stimulation of beta 2 requires 10 molecule of adrenaline. So as a result, the blood pressure will again become normal. So here we can see that the adrenaline administration shows two phases. One is increase in blood pressure and the other is decrease in blood pressure. The first increase in blood pressure was due to stimulation of alpha 1 receptor and this reduce in blood pressure was due to stimulation of beta 2 receptor. For the presence of these two phases, it is called biphase and the whole mechanism is called biphasic response of adrenaline. Now we will move to vasomotor reversal of DEL. It is nothing but the biphasic response of adrenaline only with one more term, that is an alpha blocker. If we give an alpha blocker prior to the administration of adrenaline, it will block this alpha 1 receptor. So as a result, there is no vasoconstriction and no increase in blood pressure. So now if we administer 100 molecule of adrenaline, none will work on alpha 1 receptor as it is blocked by alpha 1 blocker. So what will the blood pressure show? It will start decreasing from the beginning. Our administered 100 molecule of adrenaline now does not work on alpha 1 receptor. Rather, it acts only on beta 2 receptor. So, till the metabolism of adrenaline up to 50 molecule, the 50 molecule will work on beta 2 receptor and this response is seen. But the decrease in blood pressure will not stop. It will tend to decrease more until there is 9 molecule of adrenaline. Because in this range, this adrenaline will also work on beta 2 receptor. So as a result, the decreased in blood pressure response will be exaggerated than before. And when it reaches 9 molecule of adrenaline, the blood pressure will again increase as there is no molecule left to act on beta 2 receptor and decrease the blood pressure. So the blood pressure will be normal again. So we can notice two important thing here after giving alpha blocker. The first is there is no biphasic response. There is only one single phase. And the second thing is that the decreased blood pressure response is exaggerated. So the opposite what we are expecting has happened. This opposite is known as reversal. This phenomenon is called vasomotor reversal. Vasomotor means the effect on the muscles of blood vessel is reversed. Instead of vasoconstriction previously, we have seen in biphasic response, only vasodilation occurs. It was first noted by scientist Henry Dale. So it is called vasomotor reversal of Dale. But why are we learning about this vasomotor reversal of Dale? As we are discussing here role of adrenaline by IV route. But previously we have said that we do not use IV adrenaline usually because it is very toxic in IV route. So what is the clinical importance of learning this vasomotor reversal of Dale? Here we know that we have adrenal gland above the kidney and this also secretes adrenaline, noradrenaline. Normally this is well regulated, but when there is a tumor in the adrenal gland, it can lead to secrete excessive amount of adrenaline or noradrenaline, and both of them are sympathetic component. So increased amount of sympathetic component will lead to increase in blood pressure, and this condition is known as Pheochromocytoma. So this adrenaline which is secreted by adrenal tumor will act like the IV adrenaline as this is directly secreted into the blood. And Pheochromocytoma may be of two types, which is adrenaline producing tumor or noradrenaline producing tumor. And the symptoms of Pheochromocytoma is hypertension. Normally, to reduce blood pressure, we will use an alpha blocker, which we will discuss a little bit later. But if we use an alpha blocker in an adrenaline producing tumor, what will happen is that this vasomotor reversal phenomenon will occur. So there will be excessive decrease in blood pressure. Think that the person has adrenaline producing tumor and his blood pressure is 180. So normally we will think that by giving an alpha blocker, we will reduce this 180 BP to 120 BP. But as we discussed that in vasomotor reversal phenomenon, this alpha blocker will decrease the blood pressure more exaggeratedly, and the blood pressure may turn into 20 or 30. This is a condition of shock, and for this shock condition the person may die. So we should not use an alpha blocker in the person having adrenaline producing pheochromocytoma. Now we will move to noradrenaline producing tumor. We know that noradrenaline stimulates alpha 1, alpha 2 and beta 1 receptor. And when we block this alpha 1 receptor by alpha blocker, there will be no vasoconstriction. As a result, there is vasodilation only. And this vasodilation will convert 180 pp to 120 pp. There is no exaggerated vasodilation as there is no beta 2 receptor for stimulate and cause vasodilation. So, the decrease in blood pressure after using alpha blocker in adrenaline is very toxic and may produce death of the person, but in noradrenaline producing tumor using an alpha blocker is safe. Now my question is that can we use only beta blocker in any of this condition? The answer is no. In adrenaline producing tumor, this endogenous adrenaline will lead to stimulation of beta 2 receptor that will cause vasodilation and a decrease in blood pressure normally. So in adrenaline producing tumor, this adrenaline partially helps in reduction of blood pressure. But if we block this beta receptor by giving this beta blocker, this vasodilation will not provided. So the response will be more devastating as there is no opposing effect. This vasoconstriction will lead to suppose 220 mercury pressure, and this will lead to immediate cerebral artery rupture and stroke of the patient. So using beta blocker alone in adrenaline producing tumor is also very risky. The same thing will be applied to noradrenaline producing tumor. In noradrenaline producing tumor, some endogenous adrenaline are still producing by the adrenal gland, and this adrenaline will lead to stimulation of beta 2 and that causes vasodilation and a small reduce in blood pressure. But if we block the beta 2, the same thing will again happen and the blood pressure will more increase. So only beta blocker is contraindicated in adrenaline or noradrenaline producing tumor. So the question is how to manage hypertension in adrenaline producing pheochromocytoma. We cannot give alpha blocker. We also cannot give beta blocker alone. So the solution is to give both alpha and beta blocker. Remember, vasomotor reversal was occurring because there was unopposed action of beta 2 receptor. When we block alpha 1, only beta 2 is stimulated, which was causing vasodilation and decreasing blood pressure. So we block the beta action as well. Thus, administrating both alpha and beta blockers will prevent vasomotor reversal from occurring. So alpha plus beta blockers should be given in adrenaline producing pheochromocytoma. To summarize what we have discussed, we have adrenaline producing tumor and noradrenaline producing tumor. And we have three drugs. Those are alpha blocker only, beta blocker only, and alpha plus beta blocker. In adrenaline producing tumor, alpha blocker only is contraindicated because that will cause vasomotor reversal. On the other hand, alpha blockers only can be used in adrenaline producing tumor without any problem. However, beta blockers alone are contraindicated in both type of tumor. Alpha plus beta blockers can be given in both cases. In fact, for adrenaline producing tumor, the only effective treatment is the combination of both. Now, the last group of sympathomimetic drugs that are remaining is non-catecholamine sympathomimetic drugs. As they are not metabolized by COMT in the GIT, they can be given orally. So we will start discussion of non-catecholamines according to receptor they working on. So at first, alpha-1 receptor. The first drug that is stimulating alpha-1 receptor is phenylephrine. Phenylephrine is mainly used as eye drop. And we know that stimulation of sympathetic nervous system in eye leads to mydriasis. In our previous video, we have discussed about other drugs which were causing mydriasis, and those were anticholinergic drugs. So what is the difference between anticholinergics and phenylephrine? Phenylephrine only causes mydriasis by acting on pupillary receptors, but anticholinergic drug are causing mydriasis as well as cycloplasia. So there was blurring of vision. So phenylephrine does not cause the side effect blurring of vision, as it only causes mydriasis. Now another drug that is working on alpha-1 receptor is methoxamine. Methoxamine mainly acts on alpha-1 receptor on blood vessel, and we know that stimulation of alpha-1 receptor on blood vessel leads to vasoconstriction. So in which condition we can utilize this vasoconstriction? Yes, to emergency rise in blood pressure in emergency condition like shock or hypotension. Another drug that stimulates the alpha-1 receptor is oxymetazoline, xylometazoline. Those two drugs are used topically as nasal drop. As they works on alpha-1 receptor, they causes vasoconstriction of nasal blood vessel. This vasoconstriction will lead to reduce blood supply to the nasal mucosa. As a result, there will be less swelling and congestion in the nose. This reduced blood supply also leads to decrease in mucosal edema. So the nasal congestion is reversed, and this oxymetazoline and xylometazoline are used as nasal decongestant topically. Now, if we come to alpha-2 agonist, the drug are clonidine and alpha methyl dopa. In this video, we have discussed that the alpha-2 receptor mainly acts like a brake. So stimulation of alpha-2 receptor will cause a brake to the sympathetic nervous system. So the sympathetic outflow is reduced. And in which condition we want to reduce the sympathetic outflow? Yes, it is hypertension. By reducing sympathetic outflow, we will reduce the heart work and also reduce the vasoconstriction. Both will help in hypertension. In fact, this clonidine and alpha-methyl dopa are drug of choice in gestational hypertension. So here we have discussed about alpha-1 stimulator or alpha-1 agonist non-catecholamine and alpha-2 agonist non-catecholamines. Alpha-1 agonist non-catecholamines were phenylephrine, which were causing mydriasis but not cycloplasia like the anticholinergic drugs does. And the second drug is methoxamine, which acts on alpha-1 receptor on blood vessel and causes vasoconstriction. So this utility is used in emergency condition like shock and hypotension. The third drug is oxymetazoline or xylometazoline. These drugs are used as nasal drop and works on alpha-1 receptor, which causes vasoconstriction of nasal blood vessel, and there is reduced blood supply. that will lead to decreased swelling and decreased edema of nasal mucosa. As a result, nasal congestion is reversed. And we also discussed about alpha-2 agonist clonidine and alpha-methyl dopa. Those are stopping the sympathetic nervous system by acting as a brake, and this utility we can use in hypertension. In fact, the clonidine and alpha-methyl dopa are drug of choice in gestational hypertension. Lastly, we have drugs that stimulating beta-2 receptor. Remember, we do not have a non-catecholamine that acts on beta-1 receptor. So, on beta-1 receptor, we mainly have catecholamines like dopamine and dobutamine we previously discussed. Now, the drugs that stimulate beta-2 receptor include salbutamol, tarbutaline, salmeterol, and formoterol. They stimulate the beta-2 receptor, and stimulation of beta-2 receptor results in bronchodilation. So, these drugs are given by inhalational route and are used in bronchial asthma. We have another drug that stimulates the beta-2 receptor, and the drug name is Ritoridine. But this drug is mainly used for the action on uterus. Remember, when we have discussed about receptor, we have discussed that beta-2 is also located at the uterus. So, stimulation of beta-2 receptor of uterus leads to dilation of the uterus. So, this drug is used mainly for its tocolytic effect in preterm birth of the child. The next group of non-catecholamine that can be beta-3 agonist. The drug that stimulates the beta-3 receptor is mirabegron. Beta-3 receptor is mainly located at adipose tissue and at another location, that is our urinary bladder. So, mainly on the urinary bladder, the drug works. Beta-3 relaxes the bladder. So, the drug stimulates the beta-3 will relax the bladder. So, the drug that stimulates the beta-3 will relax the bladder. And this utility can be used in overactive bladder. So, quick recap for non-catecholamine sympathomimetics. The beta-2 receptor agonists are salbutamol, tarbutaline, salmeterol, and formoterol. As beta-2 receptor stimulation causes bronchodilation, it is used in bronchial asthma, and the route is inhalational route. Another drug that stimulates the beta-2 receptor is Ritoridine, and beta-2 receptor is located at uterus. Stimulation of uterine beta-2 receptor leads to dilation of the uterus, and this effect is also known as tocolytic effect. This tocolytic utility of Ritoridine is used for preterm birth. And beta-3 receptor agonist is mirabegron. Beta-3 receptor is located at adipose tissue and urinary bladder. Stimulation of beta-3 receptor by mirabegron on urinary bladder relaxes the urinary bladder, and we can use this utility in overactive bladder. So that is the overview of sympathetic nervous system, its receptor and the drugs that act on them. Thank you for watching this. If you found this video helpful, please like, comment and subscribe for more content.